The immune system defends our body against foreign pathogens, but it also plays a crucial role in protecting our body from malignancies. One of the hallmarks of cancer is DNA damage. Mutations accumulate in the genes that regulate cell proliferation, causing cells to become more cancerous and to start growing uncontrollably. Since cancer cells stem from mutations of normal genes, they've evolved the ability to evade and suppress the immune system. Cancer cells can have antigens that the body does not recognize as abnormal, which results in immune evasion. ALL is the most common cancer among children in the United States and occurs when there are mutations in the DNA of bone marrow cells. The bone marrow produces too many immature B cells. B cells normally help your body fight infection, but in ALL, they are abnormal and cannot fight the infection well. The immature lymphocytes crowd out the healthy cells and get into the bloodstream, accumulating in secondary lymphoid tissue and even the central nervous system. Over 80% of children diagnosed with ALL that rises in B cells will be cured by 2.5 years of intensive chemotherapy. However, effective treatments are limited for patients whose cancers return.
The treatment Kymriah was the first CAR T-cell therapy to receive FDA approval for use in patients with ALL that has relapsed. Kymriah is a single infusion therapy that trains the patient's T-cells to be able to recognize CD19 on immature cancerous B cells. The patient's T-cells are reprogrammed into CAR T-cells, which have an enhanced ability to detect and destroy cancerous B cells. Within 3 months of treatment with Kymriah, the remission rate was 83%. Chimeric antigen receptor, CAR, T-cell therapy is based on patient blood-derived T-cells, which are engineered in vitro to recognize a target antigen on cancer cells. The term chimeric has been attributed to these engineered receptors because they combine both antigen binding and T-cell activating functions into a single receptor.
The first step in making CAR T-cells is to isolate T-cells from the patient's blood. These cells are genetically engineered so that they will express CARs that are specific to a particular antigen, specifically CD19. The modified cells then replicate. Before CAR T-cell infusion, the patient is given chemotherapy over 2 to 3 days using a technique called lymphodepletion, which weakens the patient's immune system so that it does not consider the infused CAR T-cells as abnormal and eliminates them. The CAR T-cells are then returned back to the patient through IV infusion. Once infused, the CAR T-cells will continue to multiply. The engineered receptors allow these T-cells to easily recognize their targeted antigen on a cancer cell, bind to it, and exert selective cytotoxicity. The CARs are designed to endow these T-cells with highly specific homing abilities so that after reinfusion into the patient, they can act as a living drug against cancer cells.
CAR T-cells work by circulating in a patient's body and looking for cells that possess the target antigen. When the target antigen is bound, CAR T-cells become activated and multiply. Cytokines are released and signal to other immune cells to come to the site of the cancer cell. The cytokines and activated T-cells accumulate and cause localized inflammation at the cancer cell, causing the cancer cell to die. CAR T-cells can be both CD4 positive and CD8 positive. CD4 positive cells assist other blood cells to produce an immune response. CD8 positive cells are cytotoxic T cells that induce apoptosis of sick cells. CD4 positive T cells can differentiate into many subsets of effector T cells. CD4 positive helper T cells send help signals to other immune cells to make them more efficient at destroying harmful invaders. CD8 positive cytotoxic T cells seek out and destroy cancer cells by inducing apoptosis. The antigen CD19 is recognized in the cancer cell and an immunological synapse is formed. The cytotoxic T cell releases its granule contents into the synapse. Perforin induces the uptake of granzymes into the target cell cytosol. Granzyme then activates caspase-3, which is the key enzyme to induce apoptosis.
Activated CAR T cells activate innate immune cells due to the secretion of inflammatory cytokines like interferon gamma. Interferon gamma activates macrophages, which enhances their ability to kill phagocytosed antigens and secrete inflammatory cytokines. Activation of macrophages also increases the expression of molecules that are required to activate more T cells. This leads to self-amplifying inflammatory activation loop in macrophages, causing release of interleukin-1 and IL-6. Like all cancer treatments, CAR T-cell therapies can cause severe side effects. One of the most frequent and serious side effects is cytokine release syndrome, CRS. As part of their immune-related duties, T-cells release cytokines that help stimulate and direct the immune response. In the case of CRS, the infused T-cells flood the bloodstream with cytokines, causing serious side effects, including dangerously high fevers, drop in blood pressure, and in some cases, death. Ironically, CRS is considered an on-target effect of CAR T-cell therapy. The presence of CRS demonstrates that T-cells are at work in the body.
In the trial that led to FDA approval, CRS was managed using the arthritis drug Actemra. This drug blocks the activity of IL-6, a cytokine that is often secreted in large amounts by T cells and macrophages. According to the FDA, in clinical trials involving CAR T cells, 69% of the patients who received 1 or 2 doses of the arthritis drug experienced a complete resolution of CRS within 2 weeks. With this therapy, patients also have an increased risk of infection because the normal B cells are also destroyed by CAR T-cell therapy. CD19 is present on both normal B cells and cancerous ones. B cells release antibodies that bind to antigens on threatening cells and mark them for destruction. Follow-up care for patients with ALL who receive CAR T-cells includes monthly outpatient immunoglobulin infusions to prevent infections due to their decreased immune cell amounts.
Since 2017, 6 CAR T therapies have been approved by the FDA for the treatment of blood cancers. The emergence of genetically modified T cells initiated a new era for cancer therapy. CAR T cells effectively recognize, target, and destroy cancer cells through an MHC-independent mechanism. Some experts conclude that CAR T cell therapy could soon replace more chemotherapy as the standard second-line treatment for relapsed blood cancers, thus reducing treatment times and increasing the chance of remission. Thanks for watching! And check out our cool sources!